My name is Dr. Kaudia, and as the theologist working at KNH Hospital, I'll be facilitating today's meeting. A few announcements as we start. First of all, we would like to welcome all of you to this Thursday KSA B Braun webinar, and we're also inviting all our colleagues from across East Africa. Karibuni sana. The other thing I would like to point out is that kindly, if you're not on the KSA mailing list, kindly put your email address on the chat for purposes of the emailing the CPD points. Also, you can send your questions on the today's two presentation onto the chat. So without wasting more time, today we have two presenters, and both topics are touching on regional anesthesia. Our first presenter is Dr. Beryl Kaudia. Dr. Beryl is a senior resident in general surgery at the University of Nairobi, and she's going to take us through the perspective of a surgeon's perspective of regional anesthesia from something that she's been doing for the past several months. Our second presenter will be Dr. Specky, but we'll get to her later. So without, we can get right into Dr. Beryl's presentation. Dr. Karibu.
Right. As Dr. Nganga has said, my name is Dr. Beryl and I'm a fifth-year general surgery resident who has been conducting a study on the efficacy of the rectal nerve blocks for acute pain management following modified radical mastectomy for breast cancer. So the background to this comes about with the fact that we have found that over the past 2 decades, despite the adequacy of adequate techniques for pain control, patients still experience quite a bit of acute postoperative pain. Between the years of 1995 to 2013, multiple studies have been conducted in various hospitals across America just to assess the incidence of acute postoperative pain, the presence of pain management facilities in the hospital. And nearly all of these studies have found that up to 80% of patients experience acute postoperative pain with a range from mild to severe pain or even extreme pain. And for some of this is despite receiving their first dose of medication. And for some of this, we found that despite having adequate pain control, it comes about with the other negative outcome of it, the adverse effects of the medication. So we are worried about management of acute postoperative pain principally because of the complications that can arise from it. It comes along with prolonged hospital stay. You have poor early mobilization of patients and the subsequent complications of that, such as DVT and PEs. You have poor quality of life during the recovery period. Patients might be unable to sleep because of pain, or you might find that the patient is experiencing such severe pain that it actually wakes them up from their sleep. The other things are development of chronic pain syndromes. This has been studied a lot, and it has been found that patients who actually experience acute severe postoperative pain have an increased risk of developing chronic pain syndromes thereafter. It has been studied in patients who have undergone surgery for cardiac bypass, patients who had breast surgery, patients who had joint surgery.
Sorry, Dr. Beryl, the sound is not very clear on your end. Please, is something you can do about the microphone?
Can you hear me now? Is it better?
Yeah, much better.
All right, thank you for that. So in 2013, the American Pain Society and the American Society of Regional Anesthesia developed clinical guidelines for postoperative pain management. These were then published in 2016. They had multiple recommendations on acute postoperative pain management, depending on the type of surgery done and whether the patient was an adult or a pediatric patient. The recommendations was that each patient should have multimodal anesthesia, which I'm sure being an anesthesiologist, everyone is aware of. However, the exact components of what should be in the multimodal anesthesia.
Dr. Beryl, sorry, Dr. Beryl, you are getting low again. Just something about your microphone. If you could probably deal with it. Sorry.
Let me just take the volume up and see. Is this better?
Yes, that sounds better. I hope it remains so.
Yeah, if
Okay,
it could remain there.
if it can remain there. All right.
Yes.
Yeah.
So as I was saying, in 2013, we had clinical practice guidelines that were developed and published in 2016. They have multiple recommendations depending on the type of surgery and the age of the patient, but key to the recommendations is the use of multimodal analgesia for acute postoperative pain management. The other recommendation is that the key medications that should be in the multimodal analgesia is acetaminophen and an NSAID. They had identified multiple research gaps, and one of them was on the lack of data on the effectiveness of opioid-sparing multimodal regimens. And so that brings us to the key area of the study that we conducted. So our research question was to assess the efficacy of the pectoral nerve blocks in acute pain management following modified radical mastectomy at the Kenyatta National Hospital. And in order to do this, we set out these objectives. We wanted to determine the postoperative pain intensity within the first 24 hours in both groups. And these groups are patients who received the pectoral nerve block in addition to acetaminophen and dexketoprofen, and patients who received what we call standard analgesia, which was paracetamol, dexketoprofen, and tramadol. So we wanted to also compare the time to first rescue analgesia in both groups and subsequently determine the effectiveness in pain control of the PEX block as compared to the standard analgesia. Patients who had been admitted to the surgical wards were recruited into the study, and they were admitted to undergo an MRM. The block was administered under ultrasound guidance after general anesthesia was given, and we reconstituted it to 30 mils with 20 mils of bupivacaine and 10 mils of distilled water, and we added dexamethasone to this. Thereafter, we targeted the planes between the pectoralis muscles, so pectoralis major and minor, and between the serratus anterior muscle and pectoralis minor muscles. Postoperatively, we used a standard questionnaire to collect the pain intensities using the visual analog scale, and we did this at the 4th, 12th, 18th, and 24th postoperative hours. The data was entered into Excel and analyzed using SPSS version 23 for mean, median, and proportion, and comparisons were made using the Mann-Whitney U-test, chi-square, and features test as appropriate. Our statistical significance was taken at a p-value of less than 0.05. So what did we find? Initially, on assessment of our patients' baseline characteristics, we found that we have a significant difference in the weights of the patients in the two groups. And this later on bore a significance in the intensity of postoperative pain that was felt between the two groups. Using a multivariate analysis, we did a comparison of the pain intensity at the 4th, 12th, 18th, and 24th hour, and then thereafter adjusted for age, weight, the stage of the disease, whether they had gotten neoadjuvant chemotherapy, and how much morphine they had used. And we found that patients on the block intervention showed significantly lower pain scores while at rest as compared to those on the standard treatment. So this table just shows you that at 4 hours, if you compare the group who had received the block and those who had received the standard analgesia, you'll find that the median pain scores at 4 hours in the block group is 0 at rest and 1 on movement, as compared to 4 at rest and 4 on movement on the patients who had received the standard analgesia. Between the 12th to the 24th hour, the median pain scores were essentially the same between both groups, but at the 24th hour, we found a significant difference in the patients who had actually received the block. they had less pain on movement as compared to the patients who received standard analgesia. We also assessed how long it took for the patients in each group to actually request for rescue analgesia, and in this case, we were using morphine for rescue analgesia. We found that only 2 patients out of the 18 who received the block required rescue analgesia. And the initial time to rescue analgesia was actually 13 hours as compared to 7.5 hours in the patients who received standard analgesia. And out of the 22 patients who were on the arm that received the standard analgesia, 8 of them required rescue analgesia. We had a number of side effects that the patients thereafter experienced, with nausea being the key side effect. And we found that patients who had received the block had significantly lower occurrence of nausea as compared to patients who received standard analgesia. Patients who had, in terms of percentages, we found that 27.8% of the patients who received the block experienced side effects, and these are side effects varying from dizziness to weakness to nausea to vomiting, as compared to 68.2% in the group who received the standard treatment. We also tried to compare the patient satisfaction scores between the 2 groups, and overall found that there was no difference between either arm in terms of patient satisfaction, regardless of the degree of pain felt in either group. In terms of complications, we found that we had difficulty in administering the block in patients who had large tumors, in patients who had ulcerated disease, and in patients who had received neoadjuvant chemotherapy. And so for 2 patients on the block arm, rather than giving an ultrasound guided block, we did an open block after the mastectomy had been done. So looking at our results, we find that weight is a predictor of the likelihood of experiencing significant postoperative pain. And this is comparable to a study that was conducted elsewhere, where they followed up patients who'd had breast surgery, not just a modified radical mastectomy, however, and found that at 1 month, patients who had obesity had actually experienced more acute postoperative pain as compared to patients whose BMI was normal. The other thing that we have found in this study is that the PEX block provides adequate postoperative analgesia, and we found, especially at the 4th postoperative hour, patients who received the block had no pain, both at rest and on movement. And at the 24th postoperative hour, patients who had received the block had better pain control on movement as compared to patients who received standard analgesia. And this is comparable to the initial study that was actually carried out when they were testing the pectoral nerve blocks, and this was carried out by Blanco et al. We found that the PEX block provides a longer duration of analgesia as compared to standard analgesia, in view of the fact that patients who received the PEX block had a total duration of 13 hours before the initial need for rescue analgesia, as compared to people to the other arm that received standard multimodal analgesia, whose time to rescue analgesia was shorter at 7.5 hours. So in conclusion, we found that the PEX block actually provides adequate pain control for a modified radical mastectomy for breast cancer. We encountered very few side effects during the period of the study. We had 1 patient who developed a subcutaneous hematoma following block medication infiltration. However, this did not interfere with the surgery. We found that the block allows for early initiation of limb exercises and physiotherapy, and maybe ultimately it could actually lead to reduction of the rates of upper limb edema that we're seeing after we've done these mastectomies. And overall, as someone who had never done an ultrasounded pectoral block before, I found that with time, it is an easy technique to learn with few complications. Thank you.
Thanks, Dr. Beryl, for that very precise presentation. It comes in very handy. I know at this point we have several of the anesthesia senior residents who are doing studies related to at least the role of regional blocks in post-op pain control, both intra-op and post-op pain control. So this is very timely, and I'm sure we'll as we get to do more blocks as part of a post-op pain control, we'll get more of these studies. So thanks a lot.
Okay.
Next, the questions will come in a little bit later, so please don't run away. Next, we'll invite Dr. Specky Nguku. Dr. Specky is a consultant anesthesiologist working in the private sector in Machakos County. She's going to take us through the role of some of the blocks, especially regarding chronic pain management. I think she's going to tell us more in that regard. Dr. Specky?
My name is Speciosa Nguku. It's easier to call me Specky. I work in Machakos in a clinic where we work with 3 orthopedic surgeons, and I am the anesthesiologist who works with them. And what I want to talk about is ultrasound-guided interventional procedures that we mainly do for chronic pain, and kind of give a twist of what usually happens in the rural setup. So what we'll begin is I'll give you a brief overview of about back pain. What are the issues that we need to think about when you're dealing with patients with back pain? We look at some few aspects about the history and examination which can help us, and we look at I'll just talk briefly about some of the treatments that you can do, and then we'll dive directly into ultrasound guided injections. Why we are doing more of this and not fluoroscopy or blind. And then we'll also look at examples, and because of time, we'll just focus on two main ones, which will be the sacroiliac injection and piriformis injection. And then we can now have a question and answer session after that. I hope that's okay. So what is pain? Well, the easiest definition of what pain is what exactly a patient says it is. There's a quote that someone said that pain is a greater load over mankind than even death itself. So pain has been something that has been quite troubling to many patients, and it's the number one reason that patients go to hospital. So the International Association for the Study of Pain in 1979 came up with the definition of exactly what pain is, and they said it's an unpleasant sensory experience. It's unpleasant because no one likes to feel pain. It's not a pleasant sensation. It is not only accompanied by this feeling that is not good, but also has an emotional component towards it. And it may be associated with potential tissue damage or actual tissue damage. So think about it like if you put your finger next to around a flame, you could potentially injure your finger, or you could actually get your finger damaged. So it's actually associated with potential tissue damage or actual tissue damage. So when you think about the types of pain, the different ways to describe pain, we can talk about it in terms of the duration. It could either be acute or chronic, or you could talk about the specific pain characteristics, or you could further break it down. So for example, you can have nociceptive pain. Remember the example I gave of the person who has, when you put your finger next to fire and you get burnt, that's an example of nociceptive pain. And then the pain could actually also be nerve in origin, and most of those ones usually classify them as neuropathic pain. It could either be coming centrally from the brain and the spinal cord as a main source of causing the pain. For example, like in phantom pain when you have an amputation, or it could be peripherally, which you would find quite commonly with patients with diabetic neuropathy, where they have nocicept, they have neuropathic pain, and it's chronic. Or you could have a mixed picture where you could have a component of some nociceptive, some component of some peripheral neuropathy, in such situations. Then the other type could also be visceral, which is from internal organs. So when we're assessing a patient, for one of the things that we like to do is not to wait for the patient to come to the consultation room. We like to pick them from the waiting room. And as you're picking them from the waiting room, there's a lot of information that you can gather. Just by looking at how they are sitting, it can give an indication as to what is happening. For example, assuming that you have a boil in your buttock, you would not sit on that. You will try to sit as though you're trying to avoid putting pressure on that boil. So patients who have buttock-related pain, like for example piriformis, you'll see them sitting like in such a posture. So when you see someone sitting that way, it gives you a clue that wait, I could be dealing with some piriformis issue or something around the buttock as they're coming in. And as they start walking, you observe their gait and their balance. I had a patient who told me something that was quite interesting. He was walking with a shuffling gait, and he told me that his granddaughter has a very interesting sense of humor, and so he was having this bad buttock pain, and the granddaughter told him, "Babu, why are you walking like a penguin?" And it was because he was walking in a way trying to shift his weight. And so when you see someone walking like that, it gives you an indication that there's something going on around the gluteus region. You look at their balance, maybe they're walking as though they're bending, one leg is shorter than the other. It can give you an indication that this person has a limb length discrepancy, and you're trying to think what could be the cause of this problem that the patient has. Then now when the patient gets into the room, you can now get into the history. And as you get into the history, it is important to know when do they have pain? What are the characteristics of this pain? One of the common characteristics you'll hear is that patients will tell you that I feel tingling sensations. I feel things like a crawling under my skin. Sometimes I think that there are ants walking down up my leg, but then when I look, I see there are no ants. So things like that can give us indications that maybe we're dealing with neuropathic pain here. What are the things, what time does this pain get worse? Is it in the evening? Or is it do they complain of morning stiffness? So when they tell us about the timing of the pain, it gives us more clues. If something is more in the evening, you're thinking, this is something that where maybe joints are getting more strained. So could this be facet issues? If someone is complaining in the morning, I feel very tired, and somehow during the day it gets better, or the pain is worse in the morning, you're thinking, maybe it could be sacroiliac issues. So from the history, you can be able to get more information. It's also important to see what are the things that relieve this pain. And so those things can also give us additional information. For example, a patient with spinal stenosis will tell you that when I bend, I feel my pain gets better. Or for example, they'll tell you, before I used to walk, when I was young, I used to walk upright. But then nowadays, I find it's more comfortable walking with a slight stoop. So that can tell you there's maybe some spinal stenosis going on here. Then when you're examining them, they'll point to where the places that are painful. You palpate and feel the areas that are painful, which are pretty straightforward. It's good to do range of motion testing to see which is painful. For example, like if it's in the lower back, there are specific movements that you can do to see whether there is pain. For example, you ask them to bend to one side. Like remember, like when you're in PE, you'll be asked to bend to the side. You hold your waist and then you bend your head towards your waist that way. As you're doing it that way, if it triggers more pain, it gives you information. When they're bending forward, what happens? Does it make their pain worse or it relieves their pain? So that gives you additional clues. It's also important to do a neurological exam to see their reflexes and to assess their sensory innervation and how much power they have. This gives us more information, especially when you're dealing with pain that is you're thinking might have a central origin. So it's very important to document this because this can give indications as whether the patient is getting worse or better. So now to mainly, when you're focusing specifically on things like back pain, as a patient is telling you about the pain, ask them, where exactly does this pain seem to be going? Is it located in certain area? And try to map it out. I've used, sorry, this diagram is a little bit blurred, but I hope you can see it. If a patient has hip pain, they will complain about pain around the buttock area, but the pain will be on the, they will also complain of pain towards the inner part of the thigh. So when someone complains of pain in inner part of the thigh, it tells you this is more of hip pain than back pain, because all these things are near each other. It's hard to differentiate what they are. If you're suspecting a patient has disc pain or sciatica, most of that pain tends to be on the outer part of the leg, and it goes until the toes, depending on which level it is. If it is pain that is originating from the facets, if you're to look at the anatomy of the spine, we'll look later on at the example of what a facet looks like. But generally, the facets are there are these bony prominences that help articulate the two different vertebrae. So if there is some arthropathy going on around there, the patients will complain of pain, but their pain pattern will be different. This type of radiculopathy, the pain generally doesn't go to the bottom of the feet. It generally stops around there and might radiate around the waist, depending on which level it is. If it is myofascial pain, you'll find pain that is just generally around the buttock, but doesn't seem to cross down. Then the other one, which we've been finding is fairly undiagnosed as well, is sacroiliac joints. And that type of pain, the patient will classically point to the place that is painful, and they will put their finger where I'm pointing with this at the screen. They'll tell you that is a point that is usually painful. And we usually say if they point that way, then that is a positive 14th test. And this pain, if you were to look at the radiation pattern, it rarely goes beyond the shin. So they will say there's some pain that goes in the back of the thigh, and then maybe it stops around the shin there, but doesn't get quite down. So when that happens, it tells you that that is possibly sacroiliac joint pain. So before you actually move forward, before you start looking at a patient MRIs, just by getting the history and the exam, you already have an indication of what the problem could be. Many of the patients, when they're coming to see us in the clinic, they usually come with very many investigations that they have had from different places, and they want you to quickly run to the MRIs. The problem with that is that if you just jump in and go to see the MRIs, it'll cloud your judgment. And as you're examining them, you will not have an objective view. But if you go systematically observing them, by the time you're looking at these tests, you already know what you're ruling out. Many times, if you were to take 100 people in the street and do MRIs on them, 70% of them will possibly have some level of disc prolapse, and yet they do not have pain. So when you see a disc prolapse in an MRI, don't quickly assume that that is the cause of pain unless you've ascertained it from the history presentation and from the examination that this could be possibly the cause of the back pain. So I work in a rural place, and so the way we would work would maybe slightly different from my colleagues who work in the city, but I'm sure we have some similarities. And so some of the dilemmas that we have are a little bit different, and hopefully we will talk about how we've been able to overcome some of those dilemmas. So patients who are in rural areas have lack of the access to specialists is low. And so because of that, they don't have access to quick treatment. And by the time they're presenting to you, they have a lot of problems. And so just like they have difficulty in accessing specialists, ophthalmologists, neurosurgeons, name it, whatever specialist you think about, also the access to pain care is also limited. So how we are treating them we need to think a little bit more differently. So when I compare the rural versus the urban clients, there's a bit of a difference. I'm fortunate that I have worked both in the city and also in a rural setting. And when I compare these two different people, you see that there are some differences. So when you're dealing with rural patients, most of these patients tend to be much older. They are who are coming into the clinic, people who are most possibly retired. And because they're older, they come, and their lack of access or to specialist services, they come in generally poor health status. They have chronic illnesses, and their chronic illnesses are not well controlled. So you find that they have hypertension, and when you just happen to take the blood pressure is high. And the last time they had that looked at was maybe a year ago, and they've been taking the same medication all along. And then because of their financial power, the medications that they can use are limited because they don't have much money. So as you're dealing with them, you have a situation where you have patients who have all these chronic illnesses, all these other illnesses, comorbidities that you have to factor in. And some of the medications that you'd want to give them, you can't give them because they have issues. So for example, they might be having heart issues with dysarrhythmia. You give them pregabalin, it's too expensive. So you're thinking, let me give them amitriptyline, but you can't give them amitriptyline because they have arrhythmia. So your choice of medications becomes limited. Then some of the younger people are involved in a lot of manual work, and this manual work makes the pain worse. Some of them are employed, or they are working in their own chambers, but they don't have money to be able to pay labor. So you'd want to tell them, take rest, do not do this digging, which is making your back pain worse, but they can't do it because that is their livelihood. When you look at the persona of these clients, they come in two categories. Many of them are uninsured, they're casual laborers or peasant farmers, and they don't have any insurance. And if they have any insurance, they might only have NHIF or an insurance that is not, for lack of a better word, it's not a high level insurance. But so even if they are to pay for their treatment, they cannot, their purchasing power is limited. And then a big problem is that the National Social Insurance, which is NHIF, doesn't cover for these procedures like epidural, at least here in our setting. And so that becomes a limitation to patients. Then they're living in poverty. This medication I'm giving them, can I afford to give them something that costs 50 shillings per day? When you count that times 30 days, that's 1,500 a month. And that is just one medication. So poverty is always in the picture. And so thinking through this medication that I'm giving them, can they afford it? And so that is something that is usually a dilemma. Then you find these patients and you see that, yes, I have seen you have this back pain and you will need a procedure. And some of these procedures, you'll need to use fluoroscopy. For example, you have found that you've examined them, they have this radiculopathy, and then you see that now this patient will need to have a transforaminal epidural injection. If I do it the typical normal way, like the way you do a spinal, the interlaminar way, it will not work because the drug will not spread laterally. So you need to do a transforaminal. Where do you need to do it? You need fluoroscopy. Fluoroscopy is not easy to find in many of these rural places, rural areas. So those are some of the dilemmas. Then the patients belong to the surgeon, or generally they belong to the surgeon. So you're an anesthetist. So you run a pain clinic, no one will come because first of all, it's a new concept. But also some people will find that I send you patients but they still want to go back to their surgeon. So why should they spend money to come and see you, who is just going to write for their medication? So we found that when we have a procedure clinic, it actually is better than just having a pain clinic. So with our team of doctors, the orthopedic surgeons continue seeing the patients, and then they send the patients to come and see me to do procedures on them, and they go back to the orthopedic surgeon. And the good thing is, because we work as a team in a group, we're able to communicate, and the we're working together and you're on the same page. Of course, that would mean that you have to train your orthopedic surgeons to know what to do and how to be able to recognize some of these things. And so we found that was also a dilemma. Then generally, health workers hold on to patients a lot. And so sending them to a pain clinic, it will be withholding their income. When you go to any orthopedic clinic, like when I worked, for example, like in Kijabe, 70% of the patients who are coming to the clinic had lower back pain. And so if this is happening also in the city also, the orthopedic surgeon sending you all these patients, it will mean that you're eating into his bread and butter. And so you'll find it will be very quite common that the health workers will hold on to these patients. And so when they don't know what to do, the patient has complaint of back pain, they'll send them to physiotherapy. Then after that, they'll also keep changing the analgesia. And so they'll oscillate through different analgesia. Just to give you an example, the other day I was sent a text by a patient and she was sending me the list of drugs that she's currently taking. She was taking 3 different versions of aceclofenac with a muscle relaxants. She was taking Zulu MR, she was taking Myonac MR, Acepar MR, Xylitol MR, and those are 3 different versions of an NSAID with a muscle relaxant, taking all of them at once. And so the patient didn't understand that when you're taking this one, you stop these other ones. And so they were just adding and piling them on. Or you would find a situation where they go to see the doctor, they'll start them on Brufen, and Brufen doesn't work, you change to Celecoxib, or you go to a different brands of the same aceclofenac. So this brand doesn't work. So because they don't know what else to give, they will change to another brand. And so the patient is not getting better. They're just circling around that same point. Then the other dilemma you have is that you would want to run a multidisciplinary clinic or a pain management clinic. So if also they're working in the same town, you send them to come and see a physiotherapist. Then another time they come and see the surgeon, the anesthetist who's running the pain clinic. Each time the patient comes to see each of these different people, they're paying some form of consultation fee. And the costs are going up for this patient who doesn't have much money. So what can you do to ensure that this patient is able to get care that is affordable for them? Just like the patients in the urban settings, people are tired of taking medication. Someone has been taking back pain medications for years. They're tired of going for physiotherapy where they're just being given hot packs, alternating sometimes with ice and massage, and nothing new. And then you're telling this patient, now that I have recognized that you have this sacroiliac joint pain, you need to go for physiotherapy. And they're thinking, physiotherapy, what are they going to do? They're just going to burn my back and put electricity. Is that going to really help me? Then with the practices that we usually have as pain physicians, you want to do some diagnostic injections to see whether this is the cause of the pain. But these diagnostic injections are costly. So you tell them, let me inject here so that I can see whether this is the cause of your pain. And then if it is the cause of your pain, then you come back again next week and we do another injection. That won't work for them because they're thinking, I spent money to come to your clinic. Spent a lot of money on transport to get an injection. And then again, I come again after another week. So that becomes a challenge. So what are some of the things that we're thinking of doing? We've been doing same day trial. For example, when you're doing a diagnostic injection, we've been doing on the same day, the trial and the steroid. And just to explain it further, you're suspecting that someone has, for example, radiating pain that is arising from a pinched nerve, and maybe it is being compressed by a disc which has herniated in the back. So you'd want to put a needle around that disc and then around that, where that nerve is coming out from, and then you give a local anesthetic. If they feel some pain relief, okay, the first thing they will feel is the pain. Once you put in the needle there, when it reaches that position, it will produce the pain that they have. So it will tell you that this is actually the pain that they have. And then when you give them a local anesthetic, they get some relief. So then you've done your trial and you're sure that this is the cause of their pain. Then you're telling them, come back again after a week. We now do the same procedure, and then now we add a steroid. But you can be able to do the two of them at the same time. So we started doing that some years ago, and it was interesting to see that also there are Elizabeth and Thomas who work in a practice in America, and for them they also deal with they deal a lot with patients who have piriformis syndrome, and so for them they don't have to send a patient to come twice. You just come when they're doing the procedure, they'll put in the needle and they assess the response to that little anesthetic that they give you. And so when they see that you had pain and then the pain was relieved by that, then they say that that is a positive diagnostic test, and then they use the same sitting to give you the steroid. And that helps to relieve costs for the patients and the trouble of coming back again another time. Another thing is that because patients are living in deep rural areas, you'd want to do telemedicine. There are a lot of telemedicine platforms, but patients don't have some of they may not have a laptop. So how can you be able to still help them? Okay. So one of the things that you can do is using telephone consultations, where the doctors can call the patients and actually get to know how they're doing and be able to follow up on them, and also and just see how they're doing. So especially for reviews, especially at this time of Corona, the phone consultations have been quite helpful for patients. Another solution that can help bring costs down is having physiotherapy via WhatsApp. So how it would work is that a family member of the patient, you would use a smartphone, and then the physiotherapist can guide them. But this only happens after you've had the first session, and then the physiotherapist does a video physiotherapy session via WhatsApp after a while to assess whether there's any improvement. If they see that you're not getting better, then they might teach you other additional things to do or ask you to come in. And that helps to bring down costs. Other things that we've been thinking of doing are using TENS, transcutaneous electrical nerve stimulation. Simply what it is, just applying some electrodes across a painful area and then passing down a very small amount of current. And so the patient will feel some buzzing sensation, and that helps to relieve their pain. And so some of them who usually come for physiotherapy, they notice that their pain is relieved on that TENS. And so having a program of where you can hire out the machine to them and they can do that at home is quite helpful, especially for those patients who are tired of taking a lot of medications. And so seeing how to work around this, because buying the machine is expensive, but you can hire it out to them at an affordable cost. So it's very important also, as you are dealing with the rural patients, to think about their mode of transport. The patients could come in different ways. They could be walking patients who are just coming from the nearby town or near the surrounding areas. So when you do an injection for them, you know that this is a person who can walk home. So the amount of local anesthetic I will give at the time I'm doing the injection, I can give a little bit more, because they can wait a little bit until the numbness has reduced and they can walk home. If a patient we commonly ask them, how are you going home? How did you come? I came by matatu. Okay. When is the last time you can find a matatu? Nakwambia, I will come. My matatu might, the last matatu I can get is at 7 p.m. And after that, I can't get another one. So when you have such a patient and it's around 4 p.m., you know that you'll have to give them a small amount of bupivacaine so that they do not get numbness. And so that even when they're light from the matatu as they're walking home, they'll be able to walk home. But if it's a patient who came and was being driven by someone, maybe they'd hired a taxi, then you know I can give a slightly large amount of bupivacaine in that block, and you can take the patient to the car, and at least you know they'll be able to get home without any trouble. But then if a patient is driving, just like with day case procedures, you don't want to give too much bupivacaine because you do not want their legs to become numb and therefore reduce their reflexes as they're driving. So when we think about fluoroscopy guided procedures, the cost is out of this world for them. And so because of that, we find that ultrasound guided injections tend to be an affordable alternative. Just to explain, when you are doing a fluoroscopy guided procedure, at least with one of the place where we have fluoroscopy here in our town, you have to pay for the theater fee. You have to pay for the hiring of that for the use of that fluoroscopy machine. And so you'll find that the cost becomes too high and many patients cannot afford. But when you do ultrasound guided procedures, the costs are better. So what are some of the merits we found of ultrasound over fluoroscopy guidance? Because you're not having any ionizing radiation, then you're reducing the exposure to the health workers and also to the patient. Fluoroscopy, there's a lot of radiation. So ultrasound is better. With ultrasound, you're able to visualize the soft tissues and the vascular structures. Ultrasound is like the eye. It's like an eye at the end of the point of the needle, and so you can be able to see what you're injecting. So fluoroscopy, you can't quite see the soft tissue and structures. You're mainly seeing the bone, and you can assess from the level of where you're injecting, where you're going. You're not using contrast agents. Contrast agents can cause kidney issues, especially with patients who have renal insufficiency. And so fluoroscopy becomes an issue, so a dilemma. So ultrasound guided procedures might be more beneficial to such clients. Then it is portable. Many of these ultrasounds, modern ultrasounds, can fit into someone's bag, and they're less costly in terms of the procedure at that time, and also the infrastructure costs. The costs of these portable point of care ultrasounds have really come down, and when you compare them with fluoroscopy, it is affordable. Then compared to blind, which are you're using an anatomy, where you know where this place where you want to inject, the ultrasound is better because you're able to see where you're going, and therefore your delivery, your procedure becomes more effective than a blind procedure. So what are some of the demerits of ultrasound over anatomic and fluoroscopy guidance? The biggest one is that you need to master the scanning techniques. It's not like just giving a tablet and telling a patient, take this pill. This one, you have to really learn how to do these procedures. And so they are so user dependent. For you to get a good quality image, then you have to be good with your scanning technique. So if your scanning technique is not very good, then you'll not get very good images. And if you can't get very good images, then you'll not be able to see correctly where you're going. And if you can't see where you're going, then your block could possibly fail. Then ultrasound, because of the beam, has a very narrow imaging window. So the ultrasound beam is very tiny. So it kind of like cuts at a thin slice. So your needle position your needle has to be in line together with the ultrasound beam. And so because of that, it becomes a challenge to people who are not very well experienced. Then ultrasound, especially, you're not able to visualize some of the deep structures because of the artifacts. The ultrasound beam will cut through very easily through muscle and soft tissues. But when it comes and when you have a bony structure, that bone will cast a shadow. And so when it casts a shadow, anything that is inferior to that bone, you cannot be able to see it. And so if you're doing a technique using ultrasound and there's a bone in the way, and you want to inject something under the bone, it becomes a challenge. Just like in doing blind techniques, injections using anatomy guidance, ultrasound guidance in obese patients is a challenge on its own way. So why do we choose ultrasound guided procedures versus this one? So because of that, we like it because it's reliable. You can also use the same machine for regional anesthesia. It is portable. You can carry this point of care ultrasound with you from the clinic and to the operating room. It's cost effective. When you think of the setup cost of fluoroscopy, and you have to pay theater fees, most of these places would expect you to, they would want to pay a theater fee. They cannot understand that you're just going to just do an injection that is a few minutes. They want you to pay per hour, or they want you to pay a standard theater fee. So it's more affordable to patients. And then for some of the hospitals, because they want you to, you'll have to go through to theater, they'll insist that the patient is delayed, and yet this is something that someone can do and go home the same day. Then its return on investment is shorter than that of fluoroscopy. If you have a fluoroscopy machine which is in the millions, it takes longer for you to, for the institution to make back its money as compared to ultrasounds, which are less than $1 million shillings. Then it is safer and there's no ionizing radiation. So for people who are doing a lot of procedures, you're not too worried about radiation. So now we will look at some of the pain procedures that you can do under ultrasound guidance. So there are generally 3 types of procedures. There could be neuraxial procedures, which are mainly things that you've done in the midline, all the way down from the neck to the sacrum. So you can do facet joint injections, median branch block injections. You could do a caudal injection. You could do an epidural. Then you could do a peripheral nerve procedures. So anywhere where there's a nerve, you can do a nerve block, just the same way as you're doing nerve blocks with regional anesthesia. You can also do similar ones for interventional pain, but then the focus may be slightly different. So we look for today's example, we look at piriformis injection. And then the other category of procedures is the joint injection procedures. And the main focus we will talk about is sacroiliac joint injection, though you could also do in the knee, you could also do in the shoulder, these procedures under ultrasound guidance. So we look at facet joint arthropathy. This is facet joints is one of the things that we've noticed that is underdiagnosed in our population here, and mainly because when a patient complains of pain that is radiating around the waist here, they commonly think that the patient has a kidney problem. And so the patient will tell you, I've been having this back pain, and when I go to the hospital, they keep checking my kidneys. And so I have done a urinalysis, I have done a kidney ultrasound, but then they don't find anything, and the pain is not getting better. So those are some of the cues that can tell you, hey, then that in such a situation, could this patient be having some facet issues? Then as you examine them, then you can make a diagnosis. So this way, patients who generally have facet-like issues, especially if it is lumbar between 1 and 5, the pain tends to radiate around the waist. But it doesn't quite, in the front, it doesn't quite get to the umbilicus. It's kind of like stops around there. And then depending on which nerve is involved, you'll get different distribution patterns. But this pain generally does not radiate, does not get to the bottom of their legs. This type of pain the patients will complain of will be generally dull, achy. It doesn't radiate more than what the picture that you're seeing here, and is usually accompanied by a negative straight leg raising test. These patients will have pain that is worse mainly in the evenings, but during the day, in the morning when they wake up, it's better. They feel better. So what is this facet? When you're looking at the anatomy of the lower of the back, there are many things that could be causing pain in a patient. It could be muscular in origin. It could be pain that is coming from the disc. It could be pain, the disc could have prolapsed, meaning that it moves backwards and then it's pinching on the nerve. It could be some irritation in this facet joint. The facet joint is a joint that is formed by the superior articular facet of the previous vertebra. Sorry, the inferior articular process of the previous vertebra and the superior articular facet process of the inferior one. So where those two join is what we call the facet joint. And so this joint could be having some irritation or damage, either because of arthritis or wear and tear, or just plain irritation and inflammation because of overuse. And so this type of pain can be quite problematic to patients. And so so that could be a source of pain. Another source of pain could be from sacroiliac joints, which we'll talk about in the later on. So in these cases of where you have a patient who has presented with facet, the one I'd explained briefly, you would want to do an injection into the facet joint, or you could inject around there to help relieve the pain. When a way of diagnosing, the gold standard for diagnosing facet arthropathy is to do a median branch block or an intra-articular injection. So median branch block is just injecting around this nerve there. And once the pain is relieved, then it tells you that it's possibly that a patient might have facet, or is this cursor? Oh, it's here. Then, or you could directly inject there, which is not very easy, but if you're able to do that, then at least you'll be able to reduce, to diagnose that the patient has facet joint pain. The other thing the other procedures that you can do around here is you could do what is called a transforaminal epidural steroid injection. When a patient has lower back pain and it is radiating down to the legs, you'd want to know exactly which level is causing this pain. Is it coming from L1, L2, L3, 4? Where exactly is it? So you might want to do an injection, for example, a caudal, and you inject a contrast, and then you will see how the contrast spreads. And then when you see that when it is spreading, you see some places, the contrast doesn't seem to come out through that foramen. Maybe there's something that is blocking that area. So you can come and do an injection at that point. So assuming that this is the one that has a problem, if you come with your needle and you block and you bring it to that point, and the patient says, that's the place you've pointed, that you've pinched me, that's exactly that is the place that is causing the pain. And then you give a very tiny amount of local anesthetic, maybe 0.5 cc's of lignocaine, and they feel better. Then you can be able to sort out their pain. And that way, if you're giving it at this point here, it is called a transforaminal epidural steroid injection, because you are giving the medication at the point at which the nerve exits the vertebral foramen. The other way to give an epidural steroid injection is to give it in between between the lamina of this bone and this one here. So there's a space here. Just like when you're doing a spinal, you'll feel the spinous process, and then in between the two spinous processes, you pass your needle in between there. So if you do your injection there, then your hope is that if I pass my injection around here, the drug will spread both laterally. But if there's a disc that has impinged around there, then the lateral spread of that drug will not happen. So a transforaminal epidural steroid injection will be better than just doing an interlaminar one, because the interlaminar one, if there is a disc that is blocking there, it'll prevent spread of the drug there. But with the transforaminal one, you come in that direction and you can give the medication around the nerve and help bring some relief to the patient. So the traditional epidural steroid injection that is done interlaminar can be a challenge. So sometimes if you have obese patients, you'd want to try and do these injections using fluoroscopy, or you can use ultrasound to be able at least see these two places. So this injection is usually is not an easy one to do. I would recommend that you would go to it much later after you've mastered your ultrasound scanning technique. So if you were to go sequentially from the top of the spine, from the cervical down to the caudal, I'm sure you're wondering, what does ultrasound guidance help with this? And so there's some few studies that we look through that help us to see the utility of the ultrasound and the merits that it might have. So if you're to start at the cervical spine, you could do the median branch block. Just to remind, so to orient you, let me just remind you, the median branch block is you inject in there. A transforaminal, we are injecting there. We're injecting there. And so interchangeably, I will be using that, or you could, and then intraarticular, you're injecting directly into that, this articulating joint there. So I might possibly be using these terms interchangeably because they're all working in the same region. So Finian and Etheridge did a study in 2014 where they looked at median branch blocks done in C5 and C6 vertebra. And they were looking to see how accurate is the needle, where they're placing the needle. So generally what they would do, the gold standard has always been fluoroscopy. So they're comparing ultrasound guidance versus fluoroscopy. So most of these studies, what they were doing is that they used to use fluoroscopy as the gold standard, and then you do your procedure, you've put in your needle. And then, and they're working on cadavers. You do that, you see this is the needle, this is the correct position. Then you quickly do a dissection and then you see, oh yeah, I'm in the right position. Then they'll confirm that this is accurate. And so fluoroscopy became like the gold standard. So now they're comparing, how does ultrasound compare with fluoroscopy? So in this study, they would use the ultrasound. Most of these studies that I'll talk about, they would use the ultrasound, you scan, then you bring in your needle, you put it in that position. And then you say, okay, this is the position I have put it, and this is the place I want to do the block. So before you give the drug, they bring the fluoroscopy, the CM, and then they scan. And then they would inject the contrast and see the spread. And when they see the spread is the same as what is same as the pattern they expect, typically with a fluoroscopy guided, then they will say that that is an accurate position. So when they looked at C5 and C6, they found that it was accurate. That ultrasound guidance is as accurate as fluoroscopy. Then a year later, they did the same thing with C7 because it's a little bit lower. And they found that they were getting around 97% accuracy. And I think these were the Canadians who were doing that. Then they're also looking at vascular penetration. If I put in my needle, have I breached a vessel? Have I given into a vessel? So we usually aspirate to see whether before you do any procedure, the typical thing is that you always have to aspirate to see whether I'm inside a blood vessel. So they would aspirate and see. They found that with ultrasound, they're able to avoid accidental puncture into blood vessels, and they realized that it was 30%. In 30% of the cases, they were actually able to avoid because they are seeing the blood vessels. And also that was confirmed again in that other study that happened the next year where they were looking at C7. Then the Koreans were able to see that when they do the median branch blocks, they're able to avoid hitting critical vessels. In the neck, you have the carotid. You also have the vertebral arteries. And so because they're in very close proximity, because of ultrasound, you are able to avoid accidental injection into a critical blood vessel or into a nerve root. Because imagine, you see, if you accidentally inject around a nerve root in the lumbar spine, the worst that the patient will have is just some bit more numbness. But if you are up in the neck, you could end up giving a drug that will go into the nerve roots, and that is you're going very close to the brain, and just above there, above the neck there, you're having the, what do you call this thing? The spinal cord is just going straight up to the brain. So you don't want to give something that would possibly accent to the brain. So in this area, it's quite sensitive. And ultrasound, they find, because you're able to see the structures very well, then it was safer for them. these again are experienced people. They found that ultrasound is faster to perform as compared to fluoroscopy. They realized that they had fewer needle passes as compared to fluoroscopy guidance. And when they looked at the success rate, they found that the success rate between ultrasound guidance and fluoroscopy guidance were the same. The complication rates, if anything, were better, but generally they were able to avoid the same complications that you'd want to avoid in both of them. So when you go down to the lumbar spine, again, doing the same thing, Facet, MBB, or transforaminal, they found that the Koreans found that they are getting similar functional outcomes, meaning that there was less reduction in pain and pain was compared to when you compare ultrasound versus fluoroscopy guided. When you're comparing with the cadaver, you remember I was telling you that when you're comparing these injections in the fluoroscopy, they would do them on cadavers, and you'd see if I put my needle there and I confirm with a dissection, am I accurate? So they found that when they compared ultrasound, and if you were to come back later on and dissect again on that cadaver, they found that they're getting 88 to 91% accuracy, which is fairly good. The problem with lumbar spine, even with fluoroscopy, is L5S1 tends to be a nightmare because it's deeply tucked down into, you have the sacrum, and just the position of L5S1 where they join, it just tends to be a difficult one. And so both of them, both in fluoroscopy and ultrasound guidance, it's usually a nightmare. Then they found that ultrasound guidance, again, compared to fluoroscopy, takes less time to perform. They have the same analgesic effect. And when they looked at the techniques that you do, you could either do in plane or out plane. I'll explain a little bit later on, but they found that when they're doing out of plane techniques, meaning that you don't actually see the full track of the needle as you're bringing in the needle, they were able to be 80% accurate. So ultrasound guidance is quite useful in that aspect. Then when you're doing caudal injections, ultrasound guided injections, they found them to be more accurate than doing blindly, where you just palpate and you do your injection. But they found that the functional outcomes are the same. It's more accurate, but you're getting similar functional outcomes. Ultrasound guidance compared to the conventional, you're still you're not able to prevent intravascular breach in around 24% of the cases. And the main reason for that is because when you're doing a caudal, you have the bone that is casting a shadow. So you can't see underneath that bone. And so because you can't see underneath that bone, the intravascular breach, you are not able to prevent it, and they are only able to do it in 24% of the cases. The only time when caudal injections you can be able to see a little bit better is if you are doing it in the pediatric population. And in fact, I remember one friend of mine who had done more than 10,000 pediatric caudals had only got two epidural punctures, at that point in her career. And that is because in the pediatric population, the bone has not ossified, and so you can be able to see underneath that. But with the adult population, it becomes a challenge. But the advantage of ultrasound is that you're able to see the depth to the space, and therefore it helps you to be accurate, and also gives you an indication of what angle you can use, and therefore improve your accuracy and prevent an accidental dural puncture, which means just you'll end up getting a spinal. So those are what we've talked about are the use of ultrasound in the neuroaxial procedures. So what about in joints? I'll talk about sacroiliac joint because it's a joint that is, we've found that is not, people don't have much experience with it. So when you look at ultrasound guided, we're comparing it against fluoroscopy and also ultrasound against fluoroscopy guided plus cadaveric dissection. So when they looked at the analgesic effect and patient satisfaction and functional outcomes, they are the same. So ultrasound is, compared to the gold standard, is still good. You're able to avoid vessels around the sacroiliac joint, and therefore it helps. It's safe. There's less vascular breach because of ultrasound, because you're seeing where you're going, and especially if you put Doppler on, you can be able to see and prevent accidental intravascular injection. There was a debate between two guys, different people. For a long time, people were saying that sacroiliac joint injections and ultrasound guidance are not as accurate when they're comparing it to fluoroscopy. And they were saying that the ranges were up to 88%. And those were the studies that were going on until 2018 or so. And in 2019, Luigi published a study and said that they're able to get up to 96% with ultrasound guidance. And so a year later, in 2020, Byron writes to the journal, the American Journal of Physical Medicine and Rehabilitation, where this study was published by Luigi, and asked, how are you able to do that? All of us are able to just get 88%. How can you be 96%? And yet the sacrum is, you cannot be able to clearly see that because of bone artifacts. And so there was a debate about the accuracy. But Byron was able to answer back and tell them, I'm able to get 96% because I have lots of experience. I've been doing ultrasounds for more than 10 years. I'm also teaching people scanning in musculoskeletal procedures. And so because he has that, he is very good. His outcomes are better. You remember I said that ultrasound guided procedures, your accuracy gets better as you do more, because it is user dependent. And so you'll find that the range varies. So for some people, it will be 5% accurate, others will be 96%. But either way, it helps improve your accuracy. It generally takes, for some people, they find that it takes more time to perform. That was by Soneji. But other people say that you have a shorter performance time because it's less cumbersome doing compared to fluoroscopy. You know, fluoroscopy, you have to do two different views. You're doing an AP view, then you're doing a lateral view. So all that time you're moving the CM, you're spending a lot of more time. So generally they're finding that fluoroscopy guided procedures are more time consuming. But generally the consensus is that when you use ultrasound, it's generally a shorter time. There are fewer needle passes that were found with ultrasound as compared to fluoroscopy guided. So what is this SI joint? SI joint pain. Let me just jump. Sorry, just jump to this picture here. So let me just quickly describe what the sacroiliac joint is. This is a wedge-shaped joint that is formed between the sacrum here and the ilium. So where these two join is the sacroiliac joint. This joint has it's made up of two different parts. It has a fibrous element, which is wedge-shaped around here, and an articulating process here. So when someone has irritation or inflammation or arthritis around here, they present with classic sacroiliac joint pain. So that is the one we want to talk about. So these patients, how do they present? They will tell you that I have this pain, which they will point at there to around the sacral dimple, and they'll say that's a point that is painful. And when that patient says that, we say that is a positive Fortin's test, meaning that the possibly cause of pain is arising from the sacroiliac joint. So what are the examinations that you can be able to do to confirm that this is actually the position, the cause of the pain? So one of them is a distraction test. You tell the patient to lie supine, and then you apply pressure on the ilium, on the waist bone. When you touch your waist, you feel that hard bone. That's the ilium. So when you press backwards like that, and it reproduces a pain, that it's one of the tests that you would do. The other one is you ask the patient to lie on the side, and then you'd apply pressure on the ilium, that way with your hand bracing their back there. And as you press downwards, you're compressing you're compressing that joint. And if they have pain, it could be a possible causal. You could possibly say that. The other one is a Gainsling maneuver, where you ask the patient to lie on their back. Then the side that is painful, you push it downwards with one hand, and then this other leg is upwards. And as you push this one in that direction, you're pushing that one in that side. And if they have pain, you say that's a positive Gainsling maneuver. The other one is you put your hand underneath you put the hand underneath their buttock as though you're going towards the sacroiliac joint at the back, and then you apply pressure from the knee pushing downwards. And as you push downwards and you're bracing the sacroiliac joint, as you're pushing it that way, you're doing a thigh thrust. And if it elicits pain, you could say it's possibly sacroiliac pain. Then lastly, you ask the patient to lie prone, and then you put your hand across the back there, putting pressure on the sacroiliac joint, and then you push downwards. So if you have 3 out of 5 of these tests, they say possibly that you could be having sacroiliac joint pain. So what are the things that you can inject into this joint? You could either inject a steroid, you could inject a local anesthetic together the steroid, or you could inject dextrose solution. The reason why some people inject dextrose solution is that dextrose will cause irritation around that joint and hopefully lead to regeneration. And when that happens, you would say that you've had to relieve the pain on that joint. And so people have been trying to inject different things. There's a lot of interest. There's been a lot of growing interest in injecting 25% dextrose into these joints. And in many of the places, you'll find that there's an increase in what is called plurotherapy. So plurotherapy is just injecting this 25% dextrose into that joint, and it causes irritation and inflammation around there. And the hope is that through that inflammation and irritation, there's regeneration. And when the regeneration occurs, then it relieves the pain. So despite this, a lot of excitement around it, there are very few studies to actually show that it works. But subjectively, many people are saying that it tends to work a little bit better than plurotherapy, than just injecting a steroid into that joint. Why do we inject steroids into joints, like someone has knee arthritis or sacroiliac joint pain? The hypothesis, what we're thinking about is that the mechanism of action of this steroid is that it is reducing inflammation, in that area. If the nerves there, especially like if it's in the spine, it will reduce inflammation in the epidural space around the nerve root, and because of that, it has an analgesic effect, especially if you also add a local anesthetic to it. It also helps, the steroids also help inhibit phospholipase A2, which is one of the things that are problematic in chronic pain. And it also blocks the C fibers in the spinal cord. And so because of that, people inject steroids into the epidural space, and a similar. Sorry for that. I think someone's phone was on. Then so injecting steroids into joints help in that situation. So there's been a lot of interest in the sacroiliac joint because many people complain of that pain. So from our experience is I have reserved plurotherapy only for patients who have maximized the use of steroids, because with steroids you can only give so much in a year. In our practice, we avoid giving more than 4 injections a year. So you have to ask the patient, how many injections have you had in the knee, whatever it is, and count all of them. So if they're maxed that, then plurotherapy becomes an additional procedure, and it's been helpful in some of them. But again, we need data, and that data is hard to come by. There are not many studies that have been done, but it's something that is interesting to watch out for. So the sacroiliac joint, I've said, is it's fibrous and articulating. At this point here, it is wedge-shaped. It's a hard block to do because this spine cantilevers over that. And so when you put your probe across here, this thing is blocking the way. And so you need to maneuver the ultrasound in such a way that you can be able to see it. So typically how we do the block is you first get the point at which you will do a cordon. How to get the point at which you will do a cordon is that they usually see the sacral dimple around here and around here. So you draw an ipsilateral triangle as that there. And this marks usually the point at which many people kind of like do a cordon somewhere around there. So you bring your ultrasound probe there and then you scan laterally. So as you scan laterally, you will see the edge of the sacrum, and then you move your ultrasound probe caudally. And as you move caudally, you see that you might see this posterior superior iliac spine, posterior superior iliac spine of the ilium bone. You will see it there. And so the point at which you see this and a bit of the sacrum forms the sacroiliac joint there. And that's a point at which we bring down the needle in that angle like that to do the injection. So the same case, there are two ways to be able to do this injection. One way is to inject into this articular process or to inject into this fibrous process. Injecting into this low articular process is a difficult one. And the fluoroscopy guided procedures, the aim is to bring in the needle in such a manner like that you will get into this joint there. And then as you inject the contrast, you will see the contrast spread in that manner like that. Now with ultrasound guidance, sometimes it becomes harder to do this one here because this cantilevers and kind of creates a bony shadow and you cannot be able to see this area there. So this intra-articular injection, specifically with ultrasound, in my experience, I find it more difficult to do. The one that is a little bit easier to do is the injecting into this fibrous component of the sacroiliac joint. This is the lower part of this. This is the sacrum, and this is the ilium. So you're able to see the posterior superior. Your aim is to see the posterior superior iliac spine there, which is here, and this point here. So you're aiming to inject around there. And so that one is an easier one to do. There's been debate a lot about whether you should actually, for sacroiliac joint, you should actually be able to get directly into the joint or you can inject the drug around here. There are a lot of false positive, the error margin is wide because it's technically difficult to get into this position. And so some people will say that when you inject here, you're not so sure whether you're inside the joint or you've injected around the joint capsule. Or if you're coming here, are you sure you're inside the joint here or you're injecting around this area here where the lateral branches of some of these nerves that are exiting from the sacrum. So when you inject your drug around here, are you sure you've injected around these nerves or you've injected inside the joint? So because of that, some people are not so sure exactly where you've injected. But the good thing is that whether you inject inside here or around here, it tends to somehow help with the patient's pain. And maybe that's why sometimes some of the blind sacroiliac joint injections were having a failure because someone could have been injecting here thinking that they have gone inside here. And maybe at the point at which they injected, there are no nerves around there. So it's a bit of a debate around that. So just to remind you that it's a wedge-shaped joint at the superior anteriorly, and then in below it's an articulating process, articulating joint, sorry. So before you do any ultrasound guided procedure, it is good to be able to prepare your probe, and I'll just show you how we are able to prepare a probe because you don't have probe covers. That's an interesting technique that we do. And so we take the ultrasound, we'll take a gauze and hold the ultrasound that way. And the way we usually sterilize our gauze, we usually tie them with rubber bands during this, when you're sterilizing them in the steam autoclave. And so that will help hold the gauze into place. And then we pour sterile gel, as we just use the KY jelly, like the one that you use when you're doing catheterization. And you just ensure it is well put. Of course, you don't want to touch this if you're doing a sterile procedures, but the purpose of this was just for demonstration. And then wear a glove and roll the glove over. The reason why we found it is easier to use, we prefer to put the gauze like that, is that it prevents the sliding of this glove, and you're still able to do this. And this is how we would prepare probes, use them either, you can use them that way for ultrasound guided procedures, or even procedures like putting in central lines, which is a cheaper, more cost-effective method. Then I had mentioned that there are two ways to be able to do a block. There's an in-plane technique where the needle is positioned in a way that the needle, you can see the full length track of the needle, and that is called an in-plane view. So what happens is the ultrasound usually gives a thin slice. Imagine that it's a thin beam that is going in that direction. So when you're doing an in-plane, you're aligning this needle in the same plane as the ultrasound beam. And so if you're cutting a slice through, if you were to assume that you're cutting a slice through there, then you'll be able to see the needle in track. So that is called an in-plane view. When you do it that way, you're doing an injection in plane. Out of plane is you're coming to the middle of the probe, and therefore the ultrasound beam cuts across the needle, and therefore you'll only see the point of the needle. So that is called an out of plane technique. And depending on which ones you do, some of the injections could be easy or harder. So this is a video of how we do our sacroiliac injection procedure. So we usually start by first scanning remember that I had said that you first go to the point at which you, like when you're doing a cordon, that point where you've drawn an ipsilateral triangle, where you have one side here, the sacral dimple, another sacral dimple, then you draw a triangle. That point at which where you inject when you're doing a cordon, that's a place where you place the ultrasound first. And then you scan laterally. Then after you scan laterally, you start scanning going in a cephalar direction. So I'll explain, so have that in the back of your mind. So we started scanning laterally. We started scanning laterally, and you can see the lateral aspect of the sacrum, and then around up here is the upper part of the posterior superior iliac spine. So you can see that here, and then it kind of like cantilevers over this joint here. And the joint is the fibrous part. That, remember that wedge-shaped joint I talked about? It is around here. And so this is the flat part of the sacrum, and then the ilium there. So where those two join is that point here. You would want to, some people would want to come with the needle in that direction and then inject there. But I found that since you need to move from a medial to lateral point of view, I find that I keep hitting this. And so we prefer to use an in-plane technique where we're coming in straight down like this to this point. So in a short while, you'll be able to see the needle coming in. So we're just scanning to be able to see the position well and identify the joint, the sacrum, the ilium, and then this is the needle coming in into that point. How you know you're there is it you will hit the fiber, you'll get some resistance and you'll hit the fibrous part of the joint. And then once you reach there, you confirm by aspirating. It's good to do color Doppler. In this case, I didn't do the color Doppler so that it doesn't block the needle points that I was trying to show you, but you can put color Doppler here just to be sure that you're not seeing any blood vessels, and then always aspirate before you inject. So that's how we do our sacroiliac injection procedure. The other injection is, remember I had said that we've gone through neuraxal, we've gone through joint procedure injections, but then also peripheral nerves. Another one that is important to talk about is the piriformis injection. Piriformis injection. So the piriformis muscle, I'm sure for people who, if you have done ultrasound guided sciatic injections, there are different places that you could actually inject. You could inject at the level of the popliteal fossa, and as you scan upwards, you could inject the sciatic nerve at any position, going all the way until the gluteal fold. Then you come upwards towards the waist, and at any point, at some points, you could be able to inject there. So a piriformis injection, the point at which you're injecting the piriformis muscle is similar to how we used to be told in med school that when you are injecting someone in the buttock, divide the buttock into 4 parts, into 4 quadrants. And the uppermost outer point is where you would inject. The reason is you don't want to go to the lower part there, because if you inject there, you could directly inject into the sciatic nerve. So imagine you're not injecting the sciatic nerve, but the muscle above. That muscle that is above the sciatic nerve is the piriformis muscle, and is responsible for some of the pain that someone experiences, especially if they have back pain accompanied by buttock pain. So this piriformis injection is another common one that is done a lot by pain specialists, and there are several studies that have compared this injection being done using ultrasound guidance versus fluoroscopy. And they have found that even with ultrasound guidance, it is effective and you can reproduce the same results. You get similar outcomes as doing that. And if you also to do a cadaveric study where you do the injection with the ultrasound and then you dissect that cadaver and see whether your needle position was in the correct place, they found that you still get the same around that level of accuracy, which is fairly accurate. Oh, sorry, I think this is a misplaced statement there, sorry. They found that it has less time to perform when you piriformis injection using ultrasound versus when you do using fluoroscopy, mainly just because you're also doing different views, and it's easier learning it on ultrasound, because if you're used to doing regional anesthesia, then one of the easiest blocks to do is actually the piriformis one. It has the same analgesic efficacy as compared to when you're doing under fluoroscopy guidance. The out-of-plane technique, which is mainly used by many people, they have found several studies, especially this one shows that they have been able to get 80% accuracy when they're using the out-of-plane technique. I have not been able to see what rates they get with an in-plane technique. I personally prefer using an in-plane technique. So how do you do the piriformis? You remember the story I was telling you about that patient who was saying they're walking like the granddaughter was telling them they're walking like a penguin. Now that patient had piriformis pain. When you saw how he's sitting on the chair, he looked like as though he's trying to avoid sitting on a boil is in the buttock. And what he was having was irritation of this piriformis muscle. And so he would find that sitting down, driving, sitting down through a lecture if you're a student, or sitting through a church service would be impossible, and they'd have to keep standing up all the time. And the reason was, as they sit down, this muscle was pressing on the sciatic nerve, and they'll end up getting that paresthesia. So to be able to test for the piriformis pain, you'd ask the patient to lie prone, then you'd apply pressure there. Just by applying pressure there and it produces a pain, that tells you that they could be having piriformis. And then also as you stretch the piriformis muscle, the piriformis muscle comes from the ilium. No, sorry, from some parts of the ilium. Sorry, not ilium, but let me see. Some parts of the ilium and comes to attach to the lesser trochanter of the femur. So along its course there, the sciatic nerve can pierces it. And so the muscle itself can either fully cover the sciatic nerve, so the sciatic nerve could pass in between it, or the piriformis the nerve just passes underneath the muscle. So as you rotate this muscle, this leg, moving it, abducting and adducting it, and also flexing the hip, you move the muscle. And as you're stretching it, it can cause pain to the patient and it will reproduce the pain that they have. So that can be a useful way to be able to see. So as you're scanning, just to arrange your anatomy, this is skin, subcutaneous tissue, you have gluteus maximus, and you have the sacrum. You're placing your curved probe, or even a straight probe. Even if you don't have a curved probe, you can still use a straight probe if the patient is not very big. As you place it in that line, you will see the sacrum on one point, and at the end around here, you will see the greater trochanter of the femur. So at this point here, you will see a hyperechoic structure, which is a sciatic nerve, and superior to it is a piriformis muscle. So the advantage of ultrasound guided procedures is that you can be able to see if someone has piriformis irritation, you will see a fluid collection around the piriformis muscle, and some people can use that same procedure to aspirate it and bring some relief, and at the same time inject a steroid. But to confirm that you're not injecting into the gluteus maximus, you would rotate the leg. As you're rotating the leg, you will see this muscle moving. And as it is moving, then you confirm that is the piriformis. Then now you can come and you bring your needle in that direction, that this is out of plane there, and inject it. Or you can bring the needle in this direction, so you're coming in this way like that, and inject, and that's an in-plane technique. So this is an image of what where we recently did a piriformis injection. So this is a sciatic nerve. This is a piriformis muscle. It's this one around here. You can see it around there. So you're bringing in the needle like this. Needle was coming in an in-plane view. And you just stop shy there and inject the local anesthetic around there. So you can do hydrodissection where you're injecting a small amount as you're going down to be able to see where you are. So sometimes when you're not able to see the full track of the needle, hydrodissection helps you to see where you're going. And so we stopped around here, and then we injected the local around there. So this is the muscle, and there we injected a small amount of local there. Sorry, small amount of local there. So that comes to the end of my presentation. Any questions?
Okay, thanks a lot, Dr. Specky, for that detailed presentation. I'm sure it reminds us a lot on some of the blocks that we do routinely, especially for those people doing routine chronic pain interventions. We'll have a short from B Braun for partnering with KSA for many years. Karibu sana Bwana Mushiri. Now, Godfrey from B Braun, are you around? You have.
Thank you so much. My name is Godfrey. I'm from Chikari, B Braun pain therapist. So we have 10 minutes. So I will be using 5 minutes, and my colleague, Dr. Naomi from Nairobi, will use 5 minutes. So I'm an anesthetist by profession, so just want to say something about B Braun. I'll be talking about portfolio that we have in B Braun for regional anesthesia. So as everyone just knows, in anesthesia we have 3 types of anesthesia. There is a general anesthesia, regional anesthesia, and local anesthesia. So in general anesthesia we have total intravenous anesthesia, or where you can go with what you give in B Braun. We have TIVA, or total intravenous anesthesia, or we can go with sedation. We have all products for those 2 types of anesthesia, general anesthesia. And in regional anesthesia, we do have Miraxia method, or PNB, or you can call it peripheral nerve blocks. And in local anesthesia, we do offer wound infusion. So I just want to use in that few minutes, I want to show you the portfolio in B Braun in only regional anesthesia. We'll see both types, Miraxia method or either peripheral nerve blocks. In Miraxia method, we have dedicated equipment for spinal anesthesia, for epidural anesthesia, and for combined spinal epidural. And in PNB, we have single shot peripheral nerve blocks, or peripheral nerve blocks. So as I normally go deeper, but because of few minutes we have, I just want to show you our product without going inside the anatomy and physiology. So in spinal needles, we offer 3 types of spinal needles. We have Spinocan. This needle has clinker bevel, and we have Pencan with a pencil point needle, or pencil point end, or pencil point bevel, and we have Atrocan with a special bevel. What I'm going to show you. Let's start with Spinocan. Spinocan, we have all types and all sizes of Spinocan. From gauge, any gauge you can find them in B Braun, but of course in where we are now, the most popular gauge is 25, and you can find 25 with the different length. Either if you are dealing with small patients, you can find 88 millimeter, and if you are dealing with big mom or obesity people, you can find 120 millimeter. So it has a sharp bevel, which can help you to penetrate easily, but of course it is sharp. So it is cheaper compared with the other one we have with pencil point bevel. So this one is visible as a pencil at the top. So you can use it as well in different size of patients. And the best for this one, it comes with an introducer, especially gauge 25. It is easy because the package comes with an introducer, which will help you to penetrate. Otherwise, to go without introducer, it will be more somehow difficult because it's not sharp at the end. So we have this one, Atrocan as well, but this one is not on our market yet. This one is a combination of those two. It has a kind of pencil, but of course it is sharp, so it is more advanced. So maybe in future will be on our market. So those are three types we have: Speciosa, Atrocan, and Pencan. So without delay, what I just want to mention on the hub, by the end of this needle, it is easy to find CSF when you are injecting, because when you are in subarachnoid space, it is easy to see the CSF, and CSF is very clear. It will be clear on this new hub. And as I told you, it comes with introducer, start with 103 millimeter. It comes with the introducer. So we do have epidural set as well, and our epidural set has the nice cannulas where you can find cannula with the dual types, and it is market. You can see one every 1 centimeter. You can find it easily. This will help you to, when you are inserting your catheter, when you are inserting your catheter, it will be easy to find where you are and to locate the centimeter. If you want like 4 centimeter out of maybe the patient or inside, it will be easy. And those making they are in color, so it will be easy. And you have a lock connection, which will help you to fix any stage you have. So we do have, our kits are different, but in the standard one, it has needle, it has loss of resistance syringe, it has a filter, it has a catheter inside for injection, and it has also the part to fix your extension. And the extension is really nice. You don't need to go or to fix on the site of injection, which can affect, or when you see you are not in a position, it will be easy to manipulate your extension. So this is, we have also the combined, as I told you, the combined spinal and the pituitary anesthesia. So there are different types. They are normal. If you really have a chance to have a Belfix catheter or a Belfix kit for epidural, it is almost the same, plus our Pencan needle, the one I told you with a pencil point. So it is very nice, and they are all available. So in PNB, we had a very large portfolio, but now what we have on our market, we have a very small material which will help you to fix it. Because if you want maybe to order something in B Braun and you can't remember because of a lot of range or a lot of portfolio, so now we do have few materials for 3 types of peripheral nerve blocks. If you want to go with nerve stim, we do have Stimprex HNS12, which is our nerve stim. It is very nice. I supposed to talk about it, but now already a few seconds, a few minutes are already finished. So we have a Stimprex A dedicated to be used for nerve stim. We have also a Contprex C when you need to have a continuous drug administration. So with the Stimplex EA, you need just to use it when you are going to do a single injection, and it is available in different size and in different length. Start with the 35 millimeter, 50, 80, 100, 120, you can find them. So when you have, maybe when you want to use maybe nerve stim or ultrasound, and you are maybe doubting if you will be using nerve stim or ultrasound, you can buy Stimplex Ultra. Stimplex Ultra fits both sides. You can use either nerve stim or ultrasound. So just what I forget to mention is STEAM. STEAM means nerve stimulator or stimulation or nerve stim. Prex means plexus. So that means when you have, like for example here on both Stimplex and ultrasound, we have Stimplex Ultra. That means you can use it for nerve stim or ultrasound at the same time. So we do have ultrasound, but are not yet on our market. But what I want to say, we have the needle dedicated for ultrasound as well, and we call them Ultraplex. But because of this nerve stim Ultra, because of this Stimplex Ultra, you don't need this one, Ultraplex. You can use even Stimplex Ultra 360. So we have both continuous and single shot or single injection. So in just few words, I can stop here and invite my colleague Naomi to talk about gel fusing and Mosarin in a few minutes. Thank you so much.
So thank you, KSA, for this opportunity to have an online interaction with you guys. I'll be talking to us briefly about B Braun's normal saline that we've started producing in our production plant in B Braun Pharmaceutical EPZ. As you can see in the first slide, there is gelofusing, which we've already talked about with KSA in the past, and then we have the other bottle on the far right of normal saline. So that's what I'll be focusing on tonight. So basically, that's how the bottle looks like. And we already know that normal saline is a crystalloid, unlike gelofusing, which is a colloid. And just to highlight what it's used for, mostly fluid replacement, electrolyte replacement, and also for admixture of drugs which are given by infusion. And just to highlight the advantages of our bottle is the EHP free, PVC free, and latex free. And then the material is compatible with most drugs in the hospital. And then also it's a closed system container. And then it's a collapsible bottle. And then it has twin ports that are resealable after drug admixture to avoid contamination. So once you puncture the ports with a giving set and remove it, the ports will just reseal themselves. So there is no leakage, there is no contamination. Just more photos about how it looks like. Yeah. And that's all. We've already given out samples to the hospitals. Yeah, actually most hospitals we've given out samples. So yeah, normal saline is available. We'll appreciate your support, just as you've done in the past. Thank you so much. That's all from my end.
Okay, thank you, Naomi, for that short presentation and for bringing it to attention about the new normal saline from B Braun. We're sorry for the time we've run over our allocated time. Fortunately, there are not many questions. I'm only seeing a lot of appreciation for both presenters, but there's a quick one for Dr. Specky, and this regards mainly the injection. There's about the drugs used, the dosages. Let me read the question from Irori Kingangi. There is a question from Agnes Nzomo. Is a prolotherapy how much of the 25% dex do you inject? That's one of the questions. And then the other question still in that line from Dr. Mirori Kinganga is, can you briefly comment on patients' own plasma injection into the arthritic joints? And then last but not least is, what is the cost implication per session, per injection? Dr. Specky?
I'll start with the first one about the amount of dextrose that you inject into when you're doing fluorotherapy. It depends on where you're injecting. If someone has myofascial pain, where someone is having non-specific pain and you can't necessarily say they are having parts that are painful, and when you palpate, you feel some hard nodules that are very painful. Those things, we call them trigger points. So you can be able to do fluorotherapy in those areas where there are trigger points. And so the amount that you would give could be anywhere of 25%. Dextrose could be anywhere between 0.5 cc's if it's just one isolated trigger point injection, or if you're working on an whole area, like around maybe, for example, the upper back, where the scapula joins the spine. Around there, some people complain of a lot of pain there with the trigger points. And if you're injecting many trigger points there, you could end up injecting around a total of around 10 cc's. And so how we reconstitute it is we usually take 50% dextrose with a 1-to-1 ratio with 2% lignocaine, so that you get 25% dextrose and 1% lidocaine, and then you inject accordingly. If you have a large area, like if someone has myofascial pain around the sacroiliac joint, there the volume that you might end up injecting is around 10 to 20 cc's, but you're giving small micro injections. So you're injecting over a large area. You put a needle here, you're injecting along the whole tract, like though you would inject, like when you're doing a local infiltration for a small procedure, like for example, like IND, though you would inject around a long area there. So the fluorotherapy is almost in a similar way, but you're using 25% dextrose with lignocaine. So the volume varies. Experience with using platelet-rich patients on platelet-rich plasma. I personally have not done that. I have only used 25% dextrose. So I don't have experience with that. But just from reading from literature, there are very few studies that people have published. In fact, when you're studying, looking a lot about fluorotherapy, there's a lot of conversation, people are talking about it, but you don't have much studies. And so because of that, it's hard for me to make a comment, but there's been a lot of interest in it. Hopefully in the next few years or so, we might see some papers coming up. And so people are injecting dextrose, that is the most common. People are experimenting with platelet-rich plasma, not necessarily the patient's own, or maybe they can get from the blood bank, on use of stem cells. Then about the costs of the ultrasound guided injections, generally they're cheaper than the fluoroscopy. And in our practice here, the costs of ultrasound guided procedures is almost 16 times cheaper than fluoroscopy. I can give you an example. One of the injections can, like piriformis, could be around 2,700 if I do it using ultrasound guidance, which is affordable to most of my clients who are rural. And so that one you charge less, but you do volumes. So you could end up doing like around 5 a week. But then fluoroscopy, if we were to take this same patient to do this same procedure in one of the nearby hospitals, the total cost to the patient will come to around 45,000, and that would, most of the money will go towards the hospital's theater fee and hire of the CM. So that's a rough estimation.
Okay, thanks for that. There is one more question, hopefully the last question. This goes to B Braun. Someone is asking, we've recently been seeing gauge 25 pen can without introducers. What informed this decision by B Braun? This is from Dr. Steve Okello. Godfrey, are you still with us?
Yes, I am.
Okay.
So he's asking if there is some gauge 25 without introducer, right?
Without
Godfrey, let
introducers.
me answer the question.
Okay,
Hello?
okay. Yes, we can hear you.
Let me answer the question.
Yes.
To Dr. Okello, we apologize for that. If you have any in your stock, please just return them to us. We will exchange them for the ones that have the introducer. What happened was that we had a few inquiries of those gauges. So we brought in some, but we would want to standardize them to the ones with introducers. So if you have any in your stock, please just return them to us.
Okay. And still in that line, someone, Quebec Lagat commented on, has appreciated that B Braun are leaders in quality, but mentioned the hitches on public procurement because of cost. That's maybe food for thought. I think that brings us to the.
That's why we've started manufacturing locally, and we've started with LVPs, and progressively we hope that we will have more products that we can manufacture locally.
Okay. And before you go, someone is asking, Dr. Speck is asking, when will we have longer spinal gauge 22 needles and epidural needles?
Okay, this has been also an ongoing discussion, and we've gotten the feedback from various practitioners, including Specky. And our question is always on the numbers of how many are they, because also we need to check on if we bring in the large needles, what percentage are we bringing in as compared to the normal ones? So that's an ongoing logistical issue that we have to discuss internally before we deploy.
All right. All right, thanks a lot. We've come to the end of this presentation. Thanks a lot to our two presenters, Dr. Beryl and Dr. Speciosa Nguku, for your input, and also the presentation from our partners, B Braun, for those very on point presentations. Thanks a lot for everybody's participation. We look forward to this presentation, and we look forward to seeing you again next week on that same time. Thanks and good evening, everyone.